Hello, everyone. I'm Lynn Webster, Executive Vice President of Scientific Affairs at Dr. Vince Clinical Research in Overland Park, Kansas. I'm going to talk today about treatment strategies for acute and postoperative pain management. So the goals of acute pain, whether it is traumatic or postoperative, are very similar. I have listed them here on the left. Basically, it's to provide pain relief, but also to help provide ways in which we can enhance the recovery and function. We have to meet the patient's satisfactions, minimize side effects, and prevent people from developing chronic pain, which is often a complication of acute pain. And of course, we want to minimize the length of stay in a hospital if possible. On the right, you see an illustration of all of the different places where we can intervene and provide an intervention to mitigate acute pain. In some of these, they're central and some are peripheral, and we can use obviously different combinations of therapies which become multimodal in the treatment of acute or traumatic pain. Our considerations are listed here, and they should be individualized for every patient. We have to think about the medical and psychological as well as the physical conditions of the patient, what their age is, their level of fear, anxiety, and the type of procedure that they may undergo or the type of trauma that they've just experienced, the individual's personal preferences, and how they've responded to similar treatments in the past or how they expect to respond to this particular acute pain episode. There are well-known risk factors for acute postoperative pain. That is, the risk factors for developing chronic pain or complications from acute pain. And they fall into really 5 different categories, or 4 major categories: demographic characteristics and preoperative factors, psychological factors, and then there are some genetic factors. The 4 most important that have been correlated with postoperative and extended chronic pain problems are the age of the individual, that is, the younger the age, the greater the risk factor; preoperative pain history, that is, have they had chronic pain or experiences with pain in the past that predispose them to experience more pain; the type of operation, for example, thoracotomies or thoracic surgery, tends to have more long-term pain problems associated with it, and whether the level of anxiety exists. But we know that females experience more pain. People with obesity and smoking, although there's some controversy about this, appear to be risk factors. There's the sensitivity to pain, as well as a person's sensitivity to an analgesic, can affect the postoperative pain and long-term exposure or experience to chronic pain, the approach, the surgical procedure, and whether or not they've had exposure to opioids or other analgesics in the past. Depression, pain catastrophizing, expected pain, and surgical fear, as well as some genetic factors. We know that the mu-opioid receptor gene and the catechol-O-methyl transferase, as well as the BDNF, that is the brain-derived neurotropic factor, are polymorphic changes of the receptor that make some individuals more susceptible, greater risk of developing chronic long-term pain. We can look at the consensus statements, and there have been several over the last decade that have been proposed to follow for the use of acute pain, and this breaks them down into 6 major categories. In the preoperative evaluation, pain assessment and monitoring, and suggesting that there be a multimodal approach to analgesics, and whether or not a consult in pain, a pain specialist should be used, and then reevaluations and reassessment, and whether or not there is a caregiver and what that education is. Each of these categories which you can read, are important to be considered and have been proposed as a guideline for the management and treatment of people with acute postoperative pain. Fundamentally, we're looking at today treating pain in a multimodal approach. That means that we try to incorporate pharmacotherapy, interventional approaches, as well as sometimes complementary alternatives in a way to mitigate the side effects of any one treatment or the risk of any one treatment, and minimize the need for opioids and maximize the outcome. So it's always a bit of a risk-benefit analysis with each treatment. How do we get the most for the least trade-off of side effects? And so in order to do that, for more than 40 years, anesthesiologists have proposed a multimodal strategy for acute pain because that's what we do intraoperatively and postoperatively. But this is also applicable to those who are treating traumatic pain in the emergency room or in your offices. There are a list of different medications that can be used. You can see most of these that are listed here have side effects and recommended doses, which you can take a look at your leisure. I should point out that NSAIDs are often very fundamental for the treatment of acute pain and very helpful for most people, but they're not appropriate in some individuals, and you have to be cautious about using those in a universal way. And it's also important to know that each of these medications may work for some people, but not for others, and that's part of the reason why you have to have an individualized treatment plan. In the last decade, maybe even 2 decades, there's been a move away from using opioids to mitigate the amount of opioids used, and that's why the other medications that are listed here have been employed more often or whenever possible as a part of a multimodal treatment of acute pain. There's a concept of enhanced recovery after surgery that was proposed maybe a decade or more ago, which is really a multimodal, patient-centered approach to surgical care that aims to optimize the recovery and minimize stress and maximize physiologic function. In other words, it's really a multimodal approach to mitigate the use of opioids, maximize function, using non-opioids wherever possible. And some of those are listed in the left box. But then there are additional considerations like ketamine or lidocaine infusions, or even the patient-controlled analgesics that may or may not have an opioid use. Of course, the standard of care has always maintained that opioids are at least a consideration and are necessary for many patients, if not most, in acute postoperative pain and traumatic pain. But the amount of opioid that is being recommended has dramatically reduced over the last couple of decades. If we look back at the WHO, the World Health Organization's analgesic ladder for acute postoperative pain, we can see what is usually recommended for mild postoperative pain, which is NSAIDs and sometimes adjuvants, and this could be antidepressants. Moderate could be moderate postoperative pain may include some opioids. And that if you have a significant amount of pain or expected to have severe postoperative pain, they may require a strong opioid for a short period of time. But again, in a multimodal approach, so that you use some of the adjuvants that we have in the little box up here in the right corner, anxiolytics, some people use steroids, anticonvulsants, antidepressants, and even cannabinoids have been sometimes utilized. Individualize the treatment, use the treatments that have the most potential benefit for the least risk. We look at the clinical factors here, and I think there are 4 major considerations. One is, where is the care being provided? And is it a traumatic event or is it a planned surgical event? What are some of the influencing factors and the risk factors that I've just described? And what kind of communication do you have with your patients after prescribing or treating the acute episode? Where is the pharmacy? And what non-opioid treatments have been available? And unfortunately, you have to keep in mind, of course, what the insurance is willing to support, because sometimes they do dictate what therapeutic options we have at our disposal. So when we're looking at the case settings, you're looking at outpatient, that may require a different approach than somebody on the other end of the spectrum who's in the hospital, where you can provide more interventional treatments. That is, you may periaxial treatments or regional blocks, and you have the resources of an anesthesiologist who can provide these interventions. If it's an outpatient office, you're probably looking at pharmacotherapy for the most part. Sometimes you can use some cognitive behavioral therapy, but that's less available for most people in an acute setting. So the decision to prescribe specific opioids or non-opioids for the management of pain management must consider all of these at the same time. That's what's going through your mind as you're looking at your patient and you're trying to help mitigate their experience with pain, acute pain. Back in 2016, many of you will remember that the CDC guidelines recommended for prescribing opioids had recommended 3 days and no more than 7 days of an opioid. However, that didn't align with a lot of real practical considerations. There have been publications in the real world that have demonstrated, and my references are down here below, that patients under general surgery often require, on an average, between 4 to 9 days. And with some of the gynecologic health problems or surgeries, it could be 4 days to 13 days, and orthopedic procedures 6 to 15 days. Now, these are averages, so there are people who fall outside of this. Some require fewer days of opioids, but there are others who require more. All of this means is that the 2016 guidelines did not take in consideration the type of surgery that I mentioned earlier is important, and some of the other characteristics that place patients at risk of developing chronic pain. There are two other important factors. One is that opioid experienced patients may require higher amounts of opioids than people who are basically opioid naive. And a patient with a history of opioid use disorder, which is not the same thing, probably will need to be managed differently and should be managed without opioids if it is possible. Some of the requirements for an opioid are going to depend upon the pharmacokinetic and pharmacodynamics of the particular drug in that individual. And what we have to remember is that every drug has a different pharmacokinetic and pharmacodynamic response in every individual. Now, there's a range where most of it will occur within a certain range, but there are outliers, and we have to be cognizant of this and prepared to adjust our treatment plan in order to provide optimal treatment and mitigate the risk for chronic pain because of uncontrolled acute pain. The other requirements, or I should say the other factors that may depend or determine the amount of opioids following surgery or trauma would be age, obesity, pain sensitivity, and genetic heritability. All of these correlate with the amount of opioid consumption in published literature. There is another group of patients, and a growing number of these over the last decade, that we have to pay special attention to. And that are those who are under treatment for opioid use disorder, or OUD. There are really three groups of patients here, and they're really dramatically different, and how we approach them could be dramatically different. That is, those who are on methadone for OUD, those on buprenorphine and naltrexone. Now, the mechanism of these drugs, these treatments for OUD, will dictate to some degree what options we have in treating their acute or traumatic pain. That is, with methadone, that's a pure mu agonist. Buprenorphine is a partial mu agonist, and naltrexone blocks all opioid effects. So it's a opioid receptor antagonist. So if you have somebody who's on methadone, buprenorphine, or naltrexone, the risk of relapse is tremendous if you take them off. It used to be that a thought that we should taper everybody off and then they would be basically opioid naive coming into the operating room if that's where they're going to experience the acute pain. But in the last few years, it's been demonstrated that there's a less risk of relapse and more effective treatment if they're maintained on the dose that they were on when they came into the hospital or into the operating room. And then you look at a different modality of treating their pain. If they're on methadone or buprenorphine for OUD, try to find a non-opioid to treat their pain. But if they need an opioid, it needs to be a lipophilic opioid, something like fentanyl or hydromorphone, and it is additional to what they've been taking. You don't add more buprenorphine or add more methadone. You maintain that so that you can taper off the acute opioid therapy as quickly as possible, hopefully even before the end of their before their discharge, but if they're discharged within a few days. With naltrexone, of course, since their receptors are blocked, you have to find a non-opioid treatment for their pain. Ketamine is one of the treatments that have been common while they're in the hospital, but there are other strong analgesics. Toradol is a very powerful non-steroidal anti-inflammatory, but doing regional blocks will mitigate the need for any analgesic if it can be effectively used and instituted before the acute event, before surgery, and then maintained for a period of time postoperatively. So in summary, treatment of acute and postoperative pain should be tailored to the individual. Everybody's going to experience the same level of pain differently. That is, the stimulus of pain for one individual is not the same as for another individual. That is because of our behavioral experience, our lifetime experience, because of our psychological makeup, but also our genetic makeup. So we respond differently to different types of pain, different levels of pain, and to the analgesics that are provided. And that can be genetically driven as well. So we need to consider the demographics, age, genetics, medical and psychological factors. A multimodal treatment approach should always be used when possible, combining various pharmacologic and non-pharmacologic strategies. Pharmacotherapy decisions should be based on the patient's level of pain and comorbidities, not upon a prescription of a certain limited number of days of treatment, or whether or not they have opioid use disorder or not. And the opioid use should be minimized due to the risk of potential harm from opioids, which has been well documented in the literature and in the media over the last 2 decades. Thank you, and good luck.